Well, good morning, everyone. We wanted to thank you guys for joining with us today. We have an exciting panel on a really relevant topic. My name is Scott Shreeve. I'll be the host of this. I'll introduce myself a little bit more in just a minute. I wanted to just remind you that as you log in, there is going to be a poll with 4 questions. We'd love to have you answer those as you kind of enter into the chat. That'll help us kind of orient to the meeting here. We also will have a question and answer button that you can see right at the bottom of your screen. If you can push that, we'd love to take questions as we're going through the webinar, and we'll take those as we go as well as at the end. So feel free to make this interactive, and we'll go from there. So let me advance one slide here. As I mentioned, my name is Scott Shreeve, and I am a CEO and founder of Crossover Health. I'm an emergency medicine physician by background training and board certification. I've been involved the last 20 years in different areas of healthcare delivery, healthcare innovation, and this is a topic that's really critical to what we're doing, and I'm thrilled to welcome our panelists. I wanted to start first with Dina Bravata, followed by Melissa, and then Stephen. So, Dina?
Hi, it is such a pleasure to be here. Thank you so much for having me. I'm Dina Bravata. I'm a general internal medicine doc by training. I was a primary care doc for the first 16 years of my career when I was at Stanford in the health policy, health econ group. And that's where I first met Stephen. So it's been quite a while since then. I've been the co-founder or part of the founding team of a number of companies, including Castlight Health and Lyra. And I have been a longtime friend of the Crossover family and have helped to actually do some of the critical evaluations and publications of their outcomes. It's my pleasure to be able to join today's conversation.
Hello there. I am Melissa Hogan. I'm a senior vice president with Aon and have spent really the last 18 years in the consulting space, so representing our employer clients out there. I'm just realizing the only non-provider, non-physician on the panel, so happy to represent the member and client experience here. And I have really been focused on care delivery, so that's where my consulting work and focus area really lands, in particular on advanced primary care, patient-centered medical homes. I'm a certified content expert and have been looking at where the member and actual care takes place and supporting our clients in that space for about 18 years. So happy to be here today.
Hi, I'm Stephen Ezekiel. I'm Crossover's Chief Medical Officer. I'm really happy to be a part of this group today. I've been with Crossover for about 6.5 years, and in my role as Chief Medical Officer, I'm really trying to improve the quality and efficiency of care that we provide, and really the promotion of health and well-being is something that I have really been interested in throughout my career, both at Crossover and with my prior 26 years with the Department of Veterans Affairs. Like Dina, I'm a primary care internist by background, and I'm still seeing patients as part of my Crossover responsibilities.
All right. Well, thank you, Stephen. What a great panel to welcome this topic. Or to discuss this topic. So, as everyone on the call knows, employers are facing incredible challenges, rising healthcare costs, challenges with retention and productivity, and in managing through all that, there have been so many trends over the years that have come up, and we're going to talk today about advanced primary care, what the solution is, what the definition is, how it can be a benefit to employers, your workforce, and your bottom line, and how to integrate this into the overall strategy of offering health benefits. And so we thought it'd be important to kick this webinar off to set the table by defining what advanced primary care is and perhaps what it isn't. So I wanted to kick this off and maybe start with Dina, followed by Melissa, and then Stephen, just to get a feel for what it's that perspective on advanced primary care is from the industry, from the clients and consultants, employers, and then, of course, as a provider. So, Dina, love to hear your thoughts on the definition of APC.
Yeah, awesome. So I think first and foremost, like in terms of what the offering is that this is not just like an individual clinician. This is not just like one of us seeing individual patients. This is a team-based approach. And so I think it bears out, and I'm sure we'll all talk a lot more about what are the core components of that team. So there's some primary care provider, there are nurses, there are health coaches, there are mental health professionals. There are, I think, in almost every circumstance now, access to musculoskeletal care. And then depending upon the need of the population, there may be other service lines as well, right? So if this is a population, perhaps it's an industry that's outdoors all the time. There may need to be like dermatologists who are involved and so on. So I think it's a comprehensive team-based approach to delivering care. And it has to be convenient, right? And so I think in a lot of ways, what that means is that there has to be a hybrid approach, both in-person and virtual access to care. And that there has to also be a focus that the entire team is working toward, that is providing this care in the most cost-effective way, and that people are measuring all of these outcomes, including the various components of cost.
Okay, great. Melissa?
Yeah, so I think if we take what Dina set forth from the care side and translate that to what does it mean for the payers, for the employers out there, and your employees, your members, as they're seeking primary care. So from that lens, I usually talk to our clients around access. I think all clients are realizing, and we all personally realize, that getting into primary care, there's long wait times, limited hours, limited appointment availability. You often have to wait multiple months to get in to see a provider. There's lack of support between visits, lack of coordinated care. And so that gets into that, comprehensive team-based approach that Dina was talking about. I know all clients are focused on health equity as well, and that access piece. So how do we get our employees in to primary care in a timely way? Then we move on to affordability. So thinking about it from, trends, the payer trends, misaligned incentives in our fee-for-service model, healthcare costs increasing, and these inefficient care settings that are, driving those costs. And then we look at the quality piece, poor clinical outcomes when you don't have advanced primary care. So everything that Dina just spoke to really increases those clinical outcomes because you have a true team-based, integrated, care coordinated primary care that has access, same day availability or near same day availability, walk-in availability, and an experience where the care team is actually getting to know the patients, really creating that relationship with their patients. So a true primary care team and relationship based that increases their experience and their desire to know where to go, when to go, and knowing that they can get in, and that these providers and their care team truly understand their needs.
Okay, awesome. Okay, and then Stephen, your thoughts on the definition.
Thanks, Scott. So I would build on the concept of relationship. I think, part of what we want is to make sure that there's a care team that is surrounding that member and really looking at them as a whole person. I think one of the challenges with a lot of medicine is it becomes very transactional and very disease focused. And so it's looking at people as their collection of diseases rather than as a whole person. And really the focus should be on how do we actually prevent disease, mitigate the aspects of any chronic illnesses or issues that a person has, so that we're helping to improve a person's overall health and well-being and that of the population. I think in an ideal setting, you're really practicing in a biopsychosocial model of care as opposed to the traditional biomedical model. The biomedical model is very much well suited to a fee-for-service or transactional environment where you're treating the actual disease. So if someone has a urinary tract infection, you're treating that infection with antibiotics. That works very well for some of those things. But when you look at things like how we actually become healthy, or how you manage complex diseases like obesity or diabetes or hypertension, there's other factors that influence this. There's psychological and socioeconomic factors that influence this. And so ideally you want that team be looking at all of that, because when you look at what makes us healthy, only about 20% of it is, traditional medical things we think of, like imaging, procedures, or medications. The other 80% comes down to things like the environment we live in, the behaviors we have, whether or not we smoke or drink or eat well, as well as the social support we have. And so you really have to be looking at all of those things, and in that way, really have a much more comprehensive view. And I think the other advantage, as Dean had mentioned, in terms of having all these other specialists together as part of the advanced primary care team, is really having them co-located. So really in that same setting, because that's how you actually get the collaboration, the warm handoffs that really make it much easier. So just because these things might exist in a health system doesn't mean that you have team members collaborating and really getting to know the patient from different perspectives. So I think that's really, really important. And then also, we really want to make sure that we're really providing value-based care, so that we're really providing the highest quality at the best cost. And that's not just within the advanced primary care team, but that actually has to extend out into the larger medical ecosystem. So when you're referring into a specialist, you're referring into a specialist who has similar beliefs and behaves in a similar way to that advanced primary care team. And that's really how you can help not only promote health and well-being, but also constrain costs.
Yeah.
Scott, if I may, I'd love to just follow up on what Stephen just said. So to the extent that there are people listening in who may be thinking about purchasing this, right? And who may be like evaluating various potential partners, like Stephen said something so important, which is this idea of like who's on the team. And I think lots of folks would say like, oh yeah, we have mental health professionals, or we have, physical therapists standing by. And they may even use the word co-location, but I think that this is like so important that it's like definitely worth like pressure testing, right? Like, are there processes involved? Like, does the whole cross-functional team have stand-up in the morning that enables them to talk about their patients jointly? Are they like literally like in the same space, so that when someone is being seen in person, that like Stephen can like walk, like introduce the patient to the mental health professional, or the health coach, or that kind of thing? Are there technologies that enable that kind of warm handoff to happen in a seamless manner when somebody is being seen in a virtual way? So I think I think it's worth the fact that like many people are using similar words, but may actually in practice mean very different things.
Well, this is, I always laugh about that concept of like parallel play with your little kids. Like, are they really playing with each other, or are they just kind of side by side?
Totally. Yeah.
So maybe, Melissa, to that point, we have so many buzzwords in healthcare, and we have so many trends, so many things that come and go, advanced patient-centered medical home. We've had, social determinants of health, health equity, value-based care. All these terms get thrown out. Is this really something different, or is this just yet the next wave repackaged in more acronyms? How would you define it different? Is it different? Is this really something? And how will employers know the difference?
Yes. Yeah. So I think it needs to be, and it is something different, but it has to be delivered in a way. And to your point, is it really happening, or is it just buzzwords? And I always go back to, don't tell me what you're doing, tell me how you're doing it, and help us understand how this is making an impact. So yes, advanced primary care in its true delivery, with all the components, a part of it that we've just talked about, it is a game changer, and it is very different. Now, how that's applied and how you purchase it. So from the client perspective, you hear advanced primary care, you're probably thinking, well, I thought I was getting that through my carrier contracts. I thought this health system was providing that. And this is where we're really saying you have to dive deep to see how and if it's actually happening. And there are direct contracting opportunities for employers to ensure that advanced primary care is being delivered to their population. So, if you think about, regardless of your size, you can look for networks of advanced primary care. You can do direct contracting with local provider groups. You can look for national vendors such as Crossover and others that bring advanced primary care either on site or near site, that it is truly the clients, the employers getting engaged to directly ensure that all of these components of advanced primary care are being delivered, and therefore they're seeing different payment models and the improved health outcomes and the cost savings and that relationship being built, those preventative screenings improving, their emergency care use going down, their urgent care use going down, all of those things that make a difference in our clients' lives and in their trends and in their health outcomes for their employees. That's what advanced primary acute care can do. But you have to find the entry point and not just assume that because somebody is using the word advanced primary care, it's actually being delivered in that manner.
Okay, so I love both the emphasis that you and Dina just shared there. And Stephen, maybe as a provider, you can talk to this, right? You've been a primary care provider for 25 plus years. How is this different literally as you practice? What's unique about it? How is this better for the patients from the provider delivery perspective, to kind of build off of what Melissa just shared?
Yeah, so I think one of the big things is that it's moved delivery of care from being an individual to a team-based sport. Not every provider is going to be great at all things. And in many cases, probably shouldn't be the person who's delivering it. So, for example, the amount of nutritional education physicians get is shockingly small. So while they may understand the importance of it, they're probably not the right person to be delivering a discussion on, what's the best diet for somebody, or what maybe the best exercise program is. I think they can introduce it, but then the other members on the team, they're actually better able to both deliver that information, but also to follow up on it and to keep that person in contact with the primary care provider. So the primary care provider really needs to be helping to develop and define the plan, but there are other members on the team who can actually help make sure that it's well executed in the highest quality, most efficient manner. And so I think that concept of the primary care provider being part of a team and that team is working around the member is very different than what it was, say, 25 years ago, when everything was about the relationship just with the primary care provider. And I think that's a big piece of it. The other part is really the concept of measurement. I think that providers, everyone wants to believe they're doing the very best for their patients. And I think in the moment that is true, but you don't remember or recognize the things that you forgot to do or didn't do, or the opportunities that were missed. And so one of the big things about advanced primary care is really having a system of measurement. So it's establishing standards, understanding where you are now, where you want to go for both that individual and for a population, and having a way to be able to measure how you're changing over time. So it's really about that, how do you continuously improve the health of that population? And so if you're not in a situation where people want to be measured, or understand that being measured and understanding that there may be opportunities for them to improve their practice, then you're really not doing advanced primary care. And you really should be able to show in very clear and unambiguous terms what the health of the population is based upon those metrics which are most important to that population. And so I think that's another really key component of advanced primary care, because everyone believes they're delivering good care, but you really need to have objective data to be able to show how good that care is and how it is benchmarked against other providers, both within the group as well as nationally or regionally.
Okay, so we have on the screen here kind of the definition again. We don't expect people to be reading this, but very clearly articulating the differences here. And I think Melissa and Stephen, you both made the case why this is different. One of the ways you should be able to tell that advanced primary care is truly delivering something different is, again, to your point, is how we measure it. You spent your life measuring and doing outcome study. You've done work with us and many others to demonstrate the value of different care models. How is APC showing up different? How do you measure it differently? What are the expectations of driving to performance as viewed through measurement that you can speak to?
Yeah, I'd love to. And if I may, just before I talk about measurement, the second question in the Q&A actually is, I think, addressing what Stephen was just talking about. So the question is this really kind of a Kaiser type healthcare model? And, there are a variety of existing models, certainly the VA, in which many of us have worked, right, provide elements of this. But one of the things that many many, existing integrated care models don't do is ask the question, what are the needs of the specific population that I'm going to serve, right? And so, especially if this is a specific employer population, there may be very different needs based on the industry, the demographics of the employees in that population. There may be a lot of women of childbearing age, or perhaps there are older folks who are more likely to suffer musculoskeletal concerns. Whatever those needs are, right? Like, to your question, Scott, right? Like, I think it's about understanding what are the demographics of that population? What are their existing healthcare services utilization trends? Are they in the ED all of the time? Are they, do they have a lot of cancers? So that then we can begin to think about, like, what are the goals that we will have of advanced primary care, and measure those things. So I think that measurement, generally speaking, falls into a few categories. The first is engagement, obviously. And so, Melissa talked about the importance of access. You cannot help a population if you do not engage them. And so I think, generally speaking, there are a number of established metrics of engagement. They include access, right? So how timely is the access? How long does it take for someone to get a first, second, or third appointment? And then the second is, what proportion of the population is actually engaging in this model? And I think that we should talk at some point about modern mechanisms for engaging at-risk populations. Yep. Second then is, okay, so now we've engaged the population. Are we helping them? And so I think that there are a set of clinical outcomes, and this relates to what were the baseline of the population, right? So, like, are we able to drive greater cancer screenings? Are we able to get people's blood pressures and diabetes metrics under control, and so on? So the relevant clinical outcomes. And I think, Scott, you and the crossover team need to be super proud of the fact that that the crossover model has validated outcomes that demonstrate that you're able to get patients with mental health conditions, with musculoskeletal issues, into care quickly, and that you're able to drive, improvements in those areas often in fewer visits than in usual care, not advanced primary care. And then finally, I think that employers care about cost, right? And so what are the relevant buckets of cost? Again, if you have a population that historically had used the emergency department a lot, are we able to get people out of the ED, and do we show decreases in ED costs? Are we able to take care of patients in the outpatient setting so that we're driving down inpatient costs? But obviously, total cost of care is ultimately, kind of like part of the holy grail here. So just to summarize again: engagement, clinical outcomes, and total cost of care. I hope that we'll have a chance to talk a little bit about, like, referrals and some other, like, nuanced parts of the outcomes as well.
Absolutely. And Melissa, I want to follow that with, as you're working with employers, how are you guiding them to what measurements actually matter to really ensure you're getting value? What are the things that are important to employers in terms of the measurement, the metrics that APC can be delivering on this style of care?
Yep, absolutely. And there was also, I'm going to weave that in. I saw a question in the Q&A around what employers should look for in their population to understand, can APC actually solve for these problems? So let's take a step back. When I am talking with employers about, looking for opportunities, where we start looking in the data, and then we'll get to what do those outcomes look like, right? So the first things I look at in our clients' data is your preventative care screenings, your primary care utilization, right? So what % of your population is actually seeing a primary care provider, and how many of your population are getting their preventative screenings done, getting their annual preventative exam done? That's the basis. Then we look at your ER utilizations, and in particular, your avoidable ER utilizations. Are your employees just going to the ER because that's the only way that they can get in and see care, and they don't really know where to go because they don't have a primary care relationship? Then we look at urgent care. Same thing. Can I not get into my primary care doctor? So I'm just going to go to an urgent care provider. If I don't have a primary care doctor, I'll go to urgent care. That's that very, very, discoordinated, one-off, not treating a whole person just for urgent care needs. So those are the first things that we start to look at. Then we start looking at, condition management. So what are the conditions that are driving your population, and could APC help to prevent and treat those better, right? So prevention side. So is it cancer? Is it musculoskeletal? How can primary care get in to try to prevent these and ensure that they don't turn into catastrophic claims? So that's where we start in looking at, would APC make sense for your population? Then let's take it through and just give an example real quick of an actual delivery model. So say we look at that, we find all of the data there. You don't have high primary care, you don't have high preventative, you have extremely high ER utilization, you have musculoskeletal claims. So what can we do with this population? Say you have a very large population in one location. Let's look at an on-site clinic, right? So APC could be delivered through an on-site clinic where you actually bring a provider group or near site. That provider group then works solely with your population, right? So whether that's an advanced, a primary care provider, a nurse practitioner, physician assistant, whatever that looks like, whatever you need to start with the primary care. Now you have same day access. It's near site or close on hand. Your employees can get in the same day. It's one coordinated, comprehensive provider group that they can then build a relationship with. Those providers and team members are actually walking the halls of your location. They know what your job functions are, what your work functions are. They understand your culture. So now they're building that relationship, and your employees can get in and get primary care same day, next day, build a relationship. We can start getting those annual visits, those preventative screenings, doing labs, and start to focus on holistic care. Well-being coaching is a part of that, because these providers know your population. They're building those relationships. They're not just spending 15 minutes with your employees. They're spending a full 30, 45 minutes and not just addressing the sinus infection that they have, but let's talk about your mental health. Let's talk about you haven't had your annual visit. So all of this is building that relationship and starting to impact all of those initial claims that we started looking at. So then how do you measure outcomes? So those outcomes are tied back to the original data that we're looking at. What we want to see is increased primary care. So you are going to see an increase in that, because we want to get to the prevention piece. We want to get that engagement and get people to build a relationship with a primary care provider and that team, and then get the specialty care that they need, because they now know, I can walk in the door tomorrow. I can see the provider I know. They know me. They know my workplace environment. They know all of the benefits that my employer offers, because those providers know the integrated network that you all as employers are providing. So they serve as a navigator. They're helping say, you don't need to see a specialist right now. I can help you. And so those are the things we start to measure. What do those referrals look like into the employer ecosystem? What do specialty referrals look like? Because those should actually drop, because the primary care physician has more time, more focus and holistic care in his team to help prevent, I'll go see a specialist because I only have 5 minutes with you today. So specialty visits should start to drop. Urgent care ER, if you've got a provider that you can see that day or next day, those urgent care and ER visits should start to drop. And then you get to quality. If these providers are really spending this time building that relationship, focusing on prevention, total holistic care well-being, have a team to support it, then you start to see improved health outcomes. You start to see those MSK claims go down, those cancer claims go down, because, oh yeah, they got the preventative screening. It was a really long-winded answer, but hopefully that gives you an idea of, from beginning to end, what this could look like for an employer, where you start and then where you start to measure. And over time, those health outcomes are it takes time, but you are going to see improved health outcomes, which is going to lower your overall trend.
I think, I think the point that we can make, based on that, what you shared is that, again, this style of practice, this comprehensive team-based, relationship-based, can be applied against a whole set of problems for the employer, right? A whole set of clinical problems, financial issues that we can really focus on and drive better cost and quality and so forth. So to that end, if APC is truly a differentiated care model that we can define differently, and if we can measure the impact of it differently, should it be paid for differently? And maybe, Dina, from an industry perspective, does APC warrant more pay, higher pay? Is this a good model to introduce more risk payment, value-based payment? How do we think about the payment for this style of care?
Yeah, I mean, I think that for those of us who have been in the healthcare industry for a long time, right? Like the holy grail of value-based payments, right? Like, like we keep hearing about it, and yet, in so much of the healthcare system, we're still really stuck in a fee-for-service world. I think that especially employer-based access to advanced primary care is like a place, perhaps the place to really begin with novel payment models. Melissa talked about direct payments, and we can talk a little bit more about that. But I think, right, like today, most employers with whom I discuss these issues think of access to these services as an enormous health benefit, and like the incentive is having access to these services, right? And often it means access to these services at very low cost to the employee, to the member themselves. And as a result, right, that opens up the opportunity for the employer to pay. And should they be paid more was one of your questions, Scott, right? Well, I think that it's incumbent upon the provider of the primary care system to demonstrate that they are able to achieve ROI. And, one of the best ways to do that is to kind of put your money where your mouth is, right? And be willing to go at risk. And I think that we are increasingly seeing that. So I think that this is indeed a place for innovative payment models that really, like, it's such a beautiful thing, right? Like the patient, the provider, and the employer's incentives are all aligned, right? Like people are getting better care, and it's being delivered at a lower cost to the employer. But the provider is paid fairly to do so. And I think that, having a little skin in the game helps make sure that that happens.
Absolutely. And maybe to Stephen, I mean, as a provider, how does knowing that you're being measured this way and even paid to deliver this thing, how does that change your behaviors, how you practice? What is the impact of some of these newer models that typically are aligned with advanced primary care? How does that change your practice?
Yeah, so I think it really allows you to align. I think what the goals of most providers would be when they, come out of school is that they really want to improve the health and the well-being of the patients they serve and make a difference to their community. Unfortunately, the current payment model in fee-for-service really rewards you for doing things. And in primary care, the main thing you're doing is seeing people, and so it kind of perverts it perverts the incentives to be more about volume, getting people through. And so it puts a focus on what is the acute issue that's in front of you, how do we get people through, and it becomes a volume problem. And quality may occur, but it's not necessarily something that's being actively measured or really rewarded. I think, to Dina's point, when you look at what value-based payments represent for most primary care practices, it's about 6 to 7% of their overall income. So it's not really incentivized to drive quality. You've got a much bigger incentive to drive volume. And as much as people would like to think that they're doing the very best the very best for every single patient, the fact is that the need to be able to drive a certain amount of revenue is going to mean that you're perhaps emphasizing more on volume than you really are on quality. And when you've looked at advanced primary care models or more complicated models that are really focused on quality, they fail not because they don't get good outcomes. They almost invariably get really good outcomes. But the problem is that you can't support a team that is delivering care in a different way if what you're really being reimbursed for is only the time they spend with a physician. That way, the time that they're spent talking with a health coach or the time you might have with a social worker, if those things aren't being part of the package, if you're not being reimbursed for the 80% that drives health, then you're probably not going to see improvements in overall health and well-being. And so being able to change the payment model allows you to be able to align the incentives with what both the member wants and what the client wants. Because, I think, a lot of clients, when they're talking about things like HRAs, or they're looking to, to build an on-site clinic, or they're looking for a better experience, my impression is they're really trying to improve the health of their population. And when you look at how members act, they're also trying to improve their health. There's a statistics that shows that about 40% of Americans use some form of complementary integrative health practice. It's like everything from like yoga, naturopaths to vitamins. and they're doing it primarily to get healthy. And they spend about $30 billion a year on this, which is about 10% of all their out-of-pocket spending. And none of these practices are the gold standard for treating any condition, but they're all being used to try to improve overall health. And so when you actually can create a structure that allows the provider to actually examine the health and the well-being of the population, be able to do it in a proactive rather than just a reactive way, that aligns very well, I think, with what the member is hoping to get and what the employer is hoping to get. And that's an overall healthier, more productive population rather than just focused on the management of disease.
Yeah, I love that orientation. And what I've heard from every one of you is the alignment that is possible between all the parties here, the provider, the patient, and the payer, in this case, the employer. As we look at the time here, I'm going to go one question each here for each of you guys. And let me start with engagement. Melissa, one of the questions that came in from the poll here was, strong belief in advanced primary care, but it's only valuable if people use it. What are the different engagement strategies that are needed to be implemented to ensure, successful onboarding of employees into these models and encouraging their use?
Great question. Because if you don't have utilization, you're not going to get the value. So there are a couple of different answers depending on which types of APC you're utilizing. So if we think of on-site or near-site, right? You have to look at the cost structure, right? So co-payments, and Dina mentioned this, making it $0, if at all possible, that becomes an incentive. For high deductible health plans, we look at fair market value and how, obviously that needs to be considered. But look at zero to low dollar copays. That immediate access right there becomes an incentive. But you also have to think of other things like policies and procedures internally in your culture, right? So if it is if I need to leave my workstation and there's an on-site clinic, am I allowed to do that during my working hours? Or do I have to do it before or after? What is that process and that culture to support the use of advanced primary care if it's an on-site or near site? So those are kind of some of the things. I've actually had a client that has done opt-out. So they implemented an on-site clinic and everyone got an appointment in that clinic. Whether they had a primary care doctor already, that was fine. Just come see the clinic. See if, that way, if you ever need an acute need and need to get in same day, if you want to cancel the appointment, you could certainly opt out. Or, if you haven't seen a primary care provider, this is your chance to go in and have a conversation with one. And that's at, zero or low dollar copay, and the appointment's already been made for you, and it's on site for easy convenience access. So those are some, things to think about from an engagement on an on-site, near site. If you're deploying something like an ACO or variable, you want to think about variable copays, reference-based pricing, mandatory. Not that we want to go down that aspect of a stick, but there are these. You could look at mandatory, but ways to incentivize. And the most important thing, no matter the model that you're doing and you're introducing to your employees around advanced primary care, is communication on what makes it different. Because if we all think about our engagement with primary care providers in the community, it is unfortunate that we can't get in to see them, right? I can't get in to see a primary care doctor for 4 weeks, even if it's an established primary care doctor, which is why we see urgent care and ER use go up. But they spend 10 minutes with me. They don't know me. They don't know anything about, my background of my health because they're focused on what I'm in the door for that day. So you have to communicate, how is advanced primary care different, and what am I as an employee going to get out of it if I use an advanced primary care provider? And then my copay and all of the access, convenience, and policies support me utilizing that advanced primary care provider.
Okay, excellent. A related question, Dina, that I'm going to throw to you, it's also maybe an industry question, is we gotten 3 questions that talk about, hey, I love this, I'm all down with this. How do I convince my CFO that this is the right path? What data can I bring? What financials can I bring? And what is the right way to go about kind of convincing based on that this is really going to be a change for our organization to positively impact the things that we say it will?
Yeah, absolutely. Well, I mean, I think that CFOs care about financial metrics, right? And there are, and so we should speak that language. And I think that it is incumbent upon the providers to be able to demonstrate cost of care reductions, right? And, and again, Scott, I would say kudos to you and the crossover team, right? You have consistently demonstrated 30% decrease in referral rates to high cost specialists, about a 30% decrease in specialist costs, right? The crossover model, depending upon the employer, has demonstrated decreased costs for imaging, for ED utilization, right? I think that there's also, a potent CFO argument to be made around, okay, like we're paying for a telehealth vendor. And, all right, well, we don't have to do that anymore, right? Like here we have a primary care organization that provides 24/7 access to nurses and to clinicians when needed, right? We can replace part of our spending with that. We are paying for additional mental health services, perhaps, right? We no longer need to pay for that because we have this integrated into our model, so to speak. So I think that the argument to be made to the CFO, and my hope is that any potential advanced primary care partner should be able to help craft the financial argument to be made for that. And if I may, I think that there's also, so those are direct medical spend cost offsets that I think should be expected from an advanced primary care model. But there are also indirect savings here, right? So depression and mental health associated symptoms are the #1 driver of workplace disability, right? So we should be able to, and in some cases with employer partners, even measure absenteeism and presenteeism among users of the advanced primary care compared to those who aren't using it. And I think that we will demonstrate not only direct healthcare savings, but also powerful indirect costs as well.
Yeah, awesome. Again, I know we're short on time, so Stephen, let me have you bring us home with some of the innovations, some of the tools, technologies, things that you're most excited about with this model, and the things that you think will have the highest impact over the next 3 years.
So I think the ability to measure and bring in data from non-traditional sources is a potential, has the potential to have a huge impact. So I'm thinking about all the data people collect on their various watches, rings, and bands. And because I think that there's, I think there's a lot of things that people are doing to try to improve their health, but it's disconnected from their actual health care. And I think that with the advent of more virtual medicine, or the ability to integrate these other data points into the medical record, it really stands as an opportunity to be able to take where a lot of this health information is coming from and put it into a model that actually allows us to sift through it, to separate the signal from the noise. And so one of the things that I'm really excited about is being able to take a look at what is actually the health of a population. Most of our measurement models are really measuring what is the disease of a population and dressing that up as health. Like, how well controlled are the people with diabetes in your population? Well, that is an important metric, but perhaps understanding what is the rate at which people are developing diabetes or not developing diabetes might be a better metric. How healthy is that population? There's good data that if you were to look at someone's fitness level, like their VO2 max, that's actually a good predictor of how healthy they will be, and will actually correlate with morbidity, mortality, and overall healthcare spend. And so I think there's opportunities for us to be taking that type of information, coupling it with people's health information to really get a much more nuanced and hopefully much more engaging way of talking about the health of the population and what are the next best actions that individual or that client can take to improve the health of their population.
Love it. I almost feel like we're going to need a whole nother webinar on those tools and technologies, AI, the information testing, remote monitoring. So we'll get to that. So I'm going to have my panelists just take a minute to prepare their 1-minute summary while I'm going to read some of the statistics really quick on the polls that we took earlier. So about 71% of you believe that advanced primary care is a fundamentally new type of care model that should have differentiated outcomes and deliver differentiated results. So I thought that was interesting. About 40% of you were most interested in the advanced primary care definition. So hopefully we hit that clearly. We'll make sure we send these slides out to those who participated. Another 40% or so felt that their interest was on integrating APC into the benefits ecosystem. We didn't actually touch on that. I'll add one comment on that before we go. And then finally, interestingly enough, the 50% of you said, hey, I want to keep learning about this on my own. 50% wanted to talk to colleagues that have already implemented this, and 0% wanted to talk to industry experts or consultants. So that's an interesting stat there. But again, about half of the folks on the phone are employers and about half are consultants in the space. So again, thought that was interesting. So as we wrap, Melissa, why don't you take 1 minute, Dina the same, and Stephen, and give us your final summary thought on advanced primary care.
Yep. So from the client perspective, if you are an employer thinking, is this right for me? What do I have to consider? There are multiple options, whether those are on-site clinics, near-site clinics, ACOs, clinically integrated networks, national APC networks. There is an option, and it doesn't matter your size, your, where your employee population is across the United States. There are opportunities out there. Looking at the data, finding the right one is where you really need to dive in, but don't think that this is not for you. There are opportunities within your ecosystem to do direct contracting if that's what you want to do to add on to your ecosystem, but ensure that advanced primary care is part of your overall total rewards and benefits strategy and not siloed out.
Yeah. Melissa, I totally agree with what you just said. And I think that I would maybe just say that, like, now is the time, right? And I think now is the time for employers. Some of the greatest advances in advanced primary care are happening because employers are demanding it, pushing for it, and have, I think, the right to then demand the financial and other measures that we talked about. And maybe I would just say to those employers in the room, you don't have to make some gigantic investment in an on-site clinic to get started, right? You could get started in a smaller way with access to advanced primary care, perhaps near site or perhaps in a virtual model. But I think that it is important, hopefully, that you demand of your partners in this space that it is this comprehensive approach that's based in ongoing and rigorous measurement. But I'm super excited. I think that we're just going to see more and more of this.
Yeah, I would piggyback on that. I think that if you're looking to implement advanced primary care, you want to make sure that it's team-based. It is actually established around building relationships with members and spending the time with them to really understand what are the things that are going to drive health and well-being, not just the treatment of disease. And you want to be able to make sure that they are measuring and focused on those things which are most important to you as the client and to your population.
Yeah, I love it. I couldn't articulate that any better than all three of what you guys shared. So in summary, want to once again thank you for all joining with us, being a part of this community that is learning about all these different aspects of how to support employers in advancing health issues for their employees. We are absolutely convicted that advanced primary care is a fundamentally different type of model that should be measured and produce outcomes differently, should be considered to be part of new payment models that deliver this, and can become a platform and a catalyst for innovation within your benefits ecosystem. And so we hope to continue the conversation with you guys. We look forward to further feedback. You've given us a lot of suggestions for more webinars on aspects of this topic, and we can't wait to be with you guys again. So thank you very much for joining us, and much appreciated.